It's nice to see everybody today. Thank you for joining us for the Respite Voucher Learning Collaborative. I do want to just start off by saying our thoughts are with all our colleagues in Florida right now and the families they serve as they're coming out of this second monstrous hurricane within a less than 3-week period. And our thoughts are also with our colleagues and families in Georgia, North Carolina, South Carolina, and Tennessee, because I know they're still struggling to overcome a lot of the devastation that was brought by the first hurricane. Fortunately, we only have a few more weeks to hurricane season, so let's hope the remaining time is not so eventful. Please go ahead and put your names in the chat, your organization or agency, and the state you're from. You'll all have a chance to come off mute and introduce yourselves more completely when we get to the Q&A session following the presentation. I'm going to bring up, I have a few announcements. I'm going to bring up my slides and share them with you. Hope you can all see those okay. Again, I just have a couple of announcements today, and then we're going to have a presentation from our wonderful friends at the Family Caregiver Alliance in California on consumer-directed respite. And I hope you have lots of questions for them, because the opportunity to have these folks with us to ask questions of is rare and a welcome experience. So please think about your questions and the kind of information you'd like to glean from today. They have years of experience in implementing respite, and I'm just so excited myself to learn more about the day-to-day implementation issues that they face, as well as any outcomes they've experienced for family caregivers. And as I said, we'll follow that with a Q&A session after they're done. First, I wanted to make sure that you all knew about the Arch Respite Research Summit. This is the second virtual Respite Research Summit that we've held, and we're really excited about it. It'll be held the afternoons, Eastern Time afternoons of October 28th, 29th, and 30th. You can view the agendas for each day and read more about the purpose of the event and about the speakers on our summit website. And don't worry, I'll put these links in the chat in a minute. Some of the highlights, just to entice you, we're going to be releasing our second white paper on recommended common data elements for respite research that was prepared by the Arch Committee for Advancement of Respite Research. And for those of you who don't know the importance of common data elements, they really will allow, hopefully, for much improved and more meaningful comparison of data across and between studies, between different respite models, between study populations across age, disability, culture, as well as caregiving circumstances, and just being able to better compare data over time. So we're really hoping that this helps advance the field a little bit. We're also going to be among the first at this summit to learn more details about the evaluation plans for several new national initiatives that they really are direct outgrowths of the national strategy to support family caregivers. And one of them is the Guiding and Improved Dementia Experience, or GUIDE model, that's recently been implemented through the Centers for Medicare and Medicaid Innovation. We're going to have the evaluator from that project sharing with us how they plan to evaluate the program, including the respite provisions. We're going to hear more about the evaluation for the new ACL-funded Center for Dementia Respite Innovation. We'll also have a member of the research team from the National Alliance for Caregiving's Creating and Advancing Caregiving Research and Evidence Network. And this was another ACL-funded effort to advance research goal number 5 of the national strategy. So there are just a lot of exciting national initiatives, but we're also going to be hearing from a lot of local and state-funded respite initiatives that are being evaluated as well. And we're going to have a second product. We're going to be releasing a brand new guide for researchers and evaluators on how to conduct culturally and linguistically competent respite research. And we prepared that in collaboration with our friends at the Georgetown University National Center for Cultural Competence. And there's so much more. So please, I really just wanted you to be sure that you knew about those particular topics that are going to be discussed, but there's so much more. So please visit the website to see the agendas for all 3 days and more information about the amazing speakers that we have lined up for this event. I also wanted you to know our partners at the National Academy for State Health Policy recently announced a new caregiving state policy learning collaborative that will focus on state family caregiving policy that aligns with the national strategy goals. I think I mentioned this at one of our most recent learning collaboratives, but they've now opened up the call for applications from state agencies to participate. But it's not just state agency folks that can participate. The teams can have up to 4 members, one of whom needs to be an aging state agency official, which is many of you, and a Medicaid state official or administrator. But the other members can include aging and family caregiver advocacy leaders, like many of you who are with your state respite coalitions or caregiving coalitions, and state task force members. So if you're interested and you haven't heard if your state's applying and you are not the state agency, aging agency, you might want to reach out and let them know about this opportunity. They are going to select up to 16 teams, and they'll start meeting regularly in January 2025 for 18 months. And for those of you who participated in NASHB's Respite Summit in February, bringing those teams together, you know how valuable and incredible that experience was. So I really encourage you to think about applying. The deadline to apply is November 1st. And again, here is the link on the slide for how you can get more information and apply. And I'll put that in the chat in a minute as well. And now we get to move on to the event we've been waiting for. I'd like to introduce our guests. Kathy Kelly, who I've known for many decades, I think, is the executive director of the Family Caregiver Alliance. And as director, she oversees programs of the Bay Area Caregiver Resource Center, which is one of the state's networks of California Caregiving Resource Centers. And for those of you who are not familiar with the California's Caregiving Resource Centers, they really were the model and the impetus for the development of the National Family Caregiver Support Program. Kathy also oversees the National Center on Caregiving, so they have a very broad national reach as well. And under Kathy's leadership, they've really moved to a national focus, focusing on best practice interventions, policy, and research. And few people have as much experience with or knowledge about caregivers or caregiver supports than Kathy. So I'm just really glad she's here today. And I was very proud to have partnered with Kathy and with FCA for our very first Lifespan Respite TA Center grant back in 2009. And she is joined by Christina Irving, who's the Director of Client Services at Family Caregiver Alliance, and she oversees the staff of the Bay Area Caregiver Resource Center, and they provide direct services to family caregivers, including caregiver assessment, counseling, education, and support, as well as respite. And she also has many years of experience, having been with FCA for more than 13 years. So thank you both for being here and for sharing all the great, impressive work that you've done. I'm so glad we finally got the chance to do this. So I'll now turn it over to Kathy and to Christina.
Okay. Well, thank you for that very, very nice introduction, Jill. It's really a pleasure to be here today. And as Jill indicated, we've been colleagues together in the struggle to get caregiving issues and respite in particular on the radar. And I think more and more But, we started at a time where the demographics weren't so determinative as they are right now. And so the demographics of the baby boomer population was always going to be, to my estimation, the thing that pushed everything over the edge, because we have, a growing population of individuals who will be needing assistance. I'm straight in the middle of the baby boomer generation myself. But, we also have less caregivers in the future. We have 7 caregivers for every person needing assistance now, by estimates that our other colleague, Lynn Friss-Feinberg, did while she was at the Public Policy Institute. And we know when we turn this decade over in 2030, we're going to have 4. So that's just a result. Again, demographics are destiny. All of us in the baby boomer generation forgot to have children. So that's kind of where it goes. But anyway, I want to talk about respite. I'm going to just say a few words about, where we are in terms of our respite experience and how we've collected information, a little bit about the system. Christina's really going to get into the sort of nuts and bolts of how we do consumer-directed respite in the state. And we would like to have a robust conversation. So for those of you who think you're going to be anonymous, we may call on you. So I'm just giving you a fair warning. We'd like to have a lively conversation, because this is really one of the areas that is going to need complete and total attention in the future, because we're just having these shifting demographics. So I need to have the slides up. And I think, okay, let's go the next one. Okay, so we are actually in our 40th anniversary year of the Caregiver Resource Center system. It was based on a pilot project that we did in the early 80s and the mid 80s. Really, we went back and got legislation that really replicated the pilot project to 11 regional centers. And this is a statewide system. It's a little bit different. We modeled it after, just for everyone's history knowledge, after the regional centers for developmental disabilities, which means that these centers report actually directly to one state department. We've been under multiple departments: Department of Mental Health in the beginning, Healthcare Services in the middle, and now we're over in the Department of Aging. But that's a little bit different kind of structure for a statewide system to report not to a bunch of counties, but actually just directly. And that was largely intentional. Part of it was that we wanted to collect data that really told the stories of what families were facing, and also the impact of our services on those families. So we needed to have a way to get consistent information across the center, and that was sort of baked into the cake really early on. And we continue that to this day. We have annual reports that are done. We used to do them, but we now UC Davis School of Nursing and the Family Caregiver Institute conduct the evaluation. So we're at our 40th anniversary. And I just want to give a few numbers. I went back to look at how many respite cases, and it's around 100,000 families have received respite through the CRC system over these many years. On an annualized basis, it's somewhere, I don't know, it's somewhere around 12 to 1,500, I think, on an annualized basis. We do consumer-directed respite for the most part, and that's what Christina is going to talk about. But I just want to say we've also worked with communities to set up volunteer respite programs under the Brookdale model, 3 of them, 2 in one county that we serve and 1 in Napa, which we provided technical assistance for. to kind of expand the respite opportunities in those communities. And we also, besides the respite that Christina is going to speak to, we also did these pop-up respite camps for many years, which were really actually a lot of fun to do. We stopped them because of the pandemic. We haven't reinstituted them yet, but the landscape has changed in the Bay Area in terms of trying to find facilities that can accommodate anywhere from 12 to 15, 17 clients over a weekend period with paid staff and lots of volunteers for all of the activities that go on during the day and the evening hours. But we did these pop-up programs, which were really great community builders. Lots of businesses turned their staff over for their day of volunteerism type events. And they were really a lot of fun. And what surprised me overall, because we have very complex care population, what really surprised me over the years is how few people actually had to leave these weekend events overall, which I see as a sign of success, but also how many people really enjoyed being there. The clients enjoyed being there. The families felt really good about the experience, and the volunteers that came and staffed the events. So it was a win-win-win all the way around. It was, I'd really like to start them, but it's hard to find a place for everyone to be. So these are the centers there. You can see it's a big state. We have many rural and frontier communities. Doesn't seem like it because everyone thinks California looks like LA, but actually we have a lot of rural and underserved areas in the state. And consumer-directed respite is really the only way that we can provide respite in those areas. So this is the next slide. The package of services that we provide, is a lot of information referral. We have a lot of materials that are written for consumers. If you go on our website, caregiver.org, you can have access to those materials and use them. Many health facilities and other groups, use our materials. They're typically all the ones that are most in use are translated into multiple languages. So if you go under our library, we have about 400 pieces of consumer content that are really generated by the experience of our staff and what they're hearing about families. So for example, we had a number of situations. These are not common situations, but a number about worrying about guns in the home. So we did a fact sheet on guns in the home, so that you'll see there's a whole lot of material there, just really based on the kinds of problems and conditions that we see as we move along in services. So we do a lot of information referral. We do a standardized assessment, an intake and assessment process, which is where we get our data about our families. The assessment is quite involved. We know a lot about our families in terms of the types of care, the frequency of care, the extent of informal and formal supports, what are the kind of chronic care conditions, and we know about their loneliness, their stress levels, and their depression screening. So we know a lot about what families are really dealing with. Our support groups are run by our professional staff because we're dealing with very serious and complex care issues. We also have individual counseling done in-house and out-of-house. Respite is what we're going to talk about today. We do a lot of legal and financial planning information. We have consultations with elder law attorneys if necessary. And then we just do a ton of education programs, both in the Bay Area for our Bay Area community, but also we have a collaborative newsletter, which you all can actually, participate in, because these are classes that are done virtually. So for anybody anywhere, and that includes outside of California, actually can dial into these classes. There's typically about 25 to 30 classes a month. and they're done in multiple languages. Usually 25 to 30% are in other languages. So if you are looking for information in Spanish or in Chinese and other languages as well, you might want to dial into that newsletter. So we do a lot of newsletter, and these are all of our ways in which you can connect with us through that. And you can stay in touch through the Connections newsletter, which is primarily around caregiving issues. And then we do have provider and professional newsletters as well. So I think I'm just looking at anything else. Oh, respite. I pulled this information. I know that Christina, you're going to take over from here, but I just wanted to say that the respite expenditures on the CRC system level is about $3 million a year. And we have a total appropriation of $15 million. So you can see that we do really prioritize respite services. Respite is one incredible need for families, to be sure, but all of the other issues around trying to make sense of the healthcare system, the emotional impact of caregiving in the long term, because most of our clients are long-term providers of caregiving of 2 to 5 years plus. Many of them don't use paid or don't have enough unpaid resources to help them. So respite is really a critical need, but it's one of many needs that families have. But we do prioritize respite funding in the scheme of things in the total funding package. So with that, I'm going to turn it over to Christina. She can talk about respite funding and some of the other components. Go ahead.
Thanks, Kathy. So just a bit of a context in terms of where our respite funding comes from. We have contracts with our local area agencies on aging to provide respite under Title IIIe, the National Family Caregiver Support Program. So we currently have Title IIIe contracts in 4 out of our 6 counties. And then one county, we keep getting little bits of it, but not the full contract. So that's a significant source of our respite funding, in addition to the funding that we get from the state as one of the Caregiver Resource Centers. So it's that contract Kathy mentioned that is directly with the California Department of Aging. And there is respite funding under that. And so we look at our clients then under these 2 buckets where there's quite a bit of overlap, but then there are also some differences. So Title IIIe serves caregivers of people who are over 60 with various chronic health conditions, who need help with multiple ADLs or IADLs, or who have dementia. And then our eligibility criteria under the Caregiver Resource Center system is that they are caring for someone with an adult onset cognitive or neurological condition. So there's overlap. People with dementia can technically qualify for respite under either of those funding types. But then we may also see somebody who is, in their 20s with a traumatic brain injury, or in their 80s with multiple medical conditions, but no cognitive impairment. So we look at our respite both in terms of which county they live in. Do we have the Title IIIe contract? Do we not? What's the eligibility for it? And, kind of adjusting and planning out our total respite budget based on what they're eligible for, where they live, and how do we make sure that we can stretch those respite dollars as far as we can. The last few years have been helpful in terms of respite because there's been additional respite dollars through some of the COVID relief bills through ARPA and CARES. We've seen additional respite across our counties. More recently through MOCA, just to add to more crazy abbreviations, which is the Modernization of Older Californians Act. So it's state-specific money that has provided additional respite. They all have followed basically the Title IIIe criteria. So it's allowed additional respite under those buckets, even though we haven't seen a change in the Caregiver Resource Center funding. And then occasionally private foundations, we don't use a huge amount of that for respite. We usually are able to kind of meet those needs with our existing contracts, but sometimes we have people where they may not be eligible because of some of the specific criteria, and yet they are still needing that. And we occasionally kind of dip into those funds when necessary. But in talking more specifically about kind of what the respite looks like, it is very much a consumer-directed and person-centered process with the caregiver. Because we offer respite as part of our full kind of array of services, it means that we have the opportunity to do that comprehensive assessment with the caregiver before we're offering respite. That is the case the majority of the time. Exceptions to that are when we're offering an education program. There might be some other event that is appropriate for a caregiver to come to that they haven't had an assessment. And it still requires us to get all of our required demographic reporting information for our contracts. And we still then have to have a bit of a conversation to really understand the need, but it's a more specific respite request versus the way we're usually looking at respite, where we are having this more in-depth conversation with the caregiver about what their needs are, what are the needs of the person they're caring for, and helping figure out what's the most appropriate and helpful way for them to receive respite. So we have a lot of flexibility, within our requirements of our contracts and our grants, but some flexibility to make sure that respite can really meet the caregiver's needs and to be most helpful in managing their stress, allowing them to, maybe see their own doctors, get to appointments, visit with friends that they haven't seen. Sometimes people say they want respite because they just want to have some time. They can go take a nap in the other room and not have to worry about rushing in to know what's going on. We think about respite both in terms of the language needs and the culture of the family. Bay Area is very diverse. There are a lot of different languages that people speak. Clients may be monolingual, the care recipient may be monolingual, or they just may prefer to speak in their primary language, and they want to have a respite provider who can speak that language, that feels maybe a better fit culturally, who can, help prepare food and, in the culture of the care recipient. So coming from this consumer-directed model, and as we'll talk about that, it gives us more flexibility in making sure that the respite is going to be as helpful. Often people think who haven't delivered respite that it's like, oh, people need it, they want it, you've got funds, it must be so easy to deliver it. But the actual implementation for that family caregiver can be tricky. You're bringing somebody into the home that they don't know. They haven't been doing the day-to-day care that you have. And so that trust and that comfort of bringing a stranger in and having to schedule it can be a challenge. So that's part of that conversation that we really have with the family about what's the way that you're going to be most comfortable using respite, so that one, you're willing to use it, and two, that you really feel like you get that break and there's not, the majority of your brain still at home kind of worried about what's going on and is everything okay. So the options that we have for caregivers is that they can hire in-home through a private provider, somebody that they know and that they are comfortable with. And I'll talk a bit more about that as well. They can use a home care agency that FCA has a contract with. So we reach out to specific agencies and initiate contracts. And so we are able to use respite through that process. They can use an adult day program. Normally, this is done when people are considering using adult day and they're not sure, is this going to work? How is it going to go? And so they may use the respite grant to pay for, 2 to 3 days a week for a period of time. And then they can decide, is this something that we want to continue on a private pay basis, assuming that they're not eligible under Medicaid for one of the adult day health centers that are covered that way. Occasionally, people who are already using an adult day program may ask to use the respite to add an extra day or two a week beyond what their normal schedule is, because there's just things going on in their life. They want to have those extra days. So it's that difference between, this is not financial assistance to pay for care that you're already getting, but how can we add to either care that exists, or when you have no care, how do we add to it to really give that caregiver a break? And then in theory, we can use it to temporarily have the care recipient go to a care facility. So assisted living or boarded care home, when they have beds available, may allow people to stay for respite. This one, I have to say, has been less available since COVID. We've seen many more of the care facilities require a like 2-week plus minimum stay, which is often not what families want. Respite grants don't necessarily stretch far enough to really make that a possibility. So it is one that we still allow. We do not contract with as many care facilities anymore because it just isn't used as frequently. And again, some of those limitations since COVID, but we will actually do it through that private provider direct pay reimbursement route. So if a family says, I found a facility and this is the one I want to use for a few days, and they're willing to do that, then we treat that in the same way that we do as if they're hiring privately. So we've had to kind of adjust that model a little bit in recent years, just because of some of the changes with the way facilities work. The most common ways people use respite, though, are the in-home care. That's what most people are looking for and what's helpful for most. So it is then this difference between either they're hiring a private provider or they're going through a home care agency. And the way we structure the private provider, and that is the one I think that we see the majority of for us, and this is not quite true for all the other caregiver resource centers in the state. I think part of why we see such a high number of private providers, one is the diversity of our clients, and it also is the cost of home care agencies in the Bay Area. Our average rate for home care agencies now is about $40 an hour up to $45. So those respite grants don't stretch as far when we're going through an agency. So we see more people who, both because they want somebody that they know and that they are comfortable with coming in, and also because they want to feel like the grant is as impactful as it can be in terms of the number of hours. So with the private provider model, the caregiver is hiring somebody, and I will show some samples of the forms that we use in a moment, but it is really the caregiver who is hiring that person. It can be a friend, it could be an extended family member. Well, we'd like to hope that friends and family would just step in and provide breaks. It doesn't always happen unless they're getting paid. And sometimes there might be people, we've seen this with adult children who might be working hourly jobs, and they would say, I could take off hours from work to provide respite, but then financially that's difficult. So we are then sometimes able to use the respite grant to pay them so that they really are able to step in and provide that care without it being financially prohibitive to them. And then sometimes people have an attendant. It's somebody that they, found through one of the online attendant registries, that they found through word of mouth, but it is somebody who does not work for an agency and they want to be able to use that person instead. So there's several different ways that people will identify or find home care workers. If somebody does not want to use a home care agency, if they're kind of dead set against that, but they don't know a person, then we will talk with them about the process of finding a private provider, again, online attendant registries, the word of mouth of who you can connect with and potentially find a person. And one of the fact sheets that we have that Kathy mentioned is specifically on hiring and home help that gives some of those sample questions to ask, an interview, and how do you screen people when you're bringing somebody into the home. So under this model, the caregiver really supervises and schedules the person. And for respite, that generally works well, but they have to be kind of prepared to do that. When it's family or friends or somebody that they've worked with before, they're usually pretty comfortable with it. If they're bringing somebody in new, then that is a conversation we need to have about setting up a contract, setting up an understanding of what their tasks are, what their roles are going to be, what do you need them to do when they're there, so that the caregiver feels like they really get their needs met. And with this, it's a reimbursement model. So I'll show you the timesheet in a moment, but the caregiver is usually having to pay as those services are initially delivered, and they are submitting then those timesheets to us for reimbursement. Occasionally we'll find that people are able to hire somebody who's willing to wait for their payment until the caregiver gets reimbursed. But for the most part, people coming into the home to provide care, they want to get paid as it's delivered. So this is a conversation that we have with the caregiver. Is that financially possible for them? And there are occasionally clients where it is not. They cannot pay out of pocket, even knowing that they're going to get reimbursed. And so while this may be their preferred method, and we talk about kind of are there ways that it can work, there are times where somebody says this is not going to be an option for me because they are not able to pay up front. And then the person they're hiring may not be willing to wait for the reimbursement to come through. But it is a way that we just need to be able to show before we pay, and as we report to our funders, that yes, the services will provide it. When we go through a home care agency, we have an agreement with that agency. So between us and them, we only contract with agencies that we have feedback on, that we have some relationships with, that we can say to the caregiver, we've had good experiences. We feel like they are trustworthy and reliable, and we are willing to kind of have this agreement and this arrangement with them. And so we contract, they then bill us directly. We will initiate that contact with the agency to let them know we have a client who is ready to use Respite. Here's kind of when they're thinking about using it or how they want to use it, providing just that basic overview of information. And then the agency will reach out to the caregiver to kind of follow up on next steps and to get it actually scheduled. So our workload for it varies maybe a little bit, again, if it's an agency versus the private hire, but they're fairly similar. And again, most of our clients are hiring somebody privately. So it really starts with our family consultant. That's our kind of social work equivalent position. They are doing the assessments and the ongoing support with caregivers. And so often the discussion of Respite comes up on the initial assessment. It may come up later. We have clients that we have worked with for years. And so they will kind of circle back to us around Respite over time and as needs change. But one of the key things that we have found is really having that conversation with the caregiver about how do you want to use that Respite time? What are your plans? What are your goals? What are you hoping to do with that time off? And it's not meant to be let's evaluate whether that's a good use of your Respite, but just wanting the caregiver to think about what do they want to do with that time off, so that they, one, don't kind of overschedule themselves, so that they use that Respite to try and do a million things on their to-do list that ends up adding more stress to their life, or then they feel like it wasn't successful because they weren't productive enough. So wanting the caregiver to be able to think about, all right, when you have this break, what's going to be helpful for you? What do you want to use with that time? And sometimes it is, I've got doctor's appointments and there's no other time I can get to do it. And that, if that's what they're wanting to use, then that's great. That's what works for them. But just having that conversation and then really talking through the options for Respite. And because we have done an assessment and we know these clients, we can talk with them based on the things that they're telling us, what feels like it's going to be the right fit for them. Do you know somebody that you're comfortable with hiring? If the care recipient has been very hesitant to bring in strangers into the home, okay, there's someone you know that you could bring in that they might be a little bit more comfortable with and who's going to be a better fit. If we know that they don't have a lot of family support, it's like, all right, we may have to go the route of going through an agency. Here's what that would look like. Let's talk about what some of the potential challenges are if you have somebody brand new who doesn't know you, doesn't know your family member coming into the home, and how do you kind of plan for that and schedule for that. Because we do have a very kind of complex client caseload, we may see people with very high medical needs. So having to talk about what are the limitations of home care agencies and where really hiring privately may be the better option, because you are not going to be able to get an agency to cover some of the care needs unless you go to really a licensed home health agency, and then we're going to see the cost even increase. We will also talk about that in terms of, dementia training, and again, having somebody with that experience who can provide that care. And then it's figuring out kind of what that hourly or daily rate is. When people are hiring privately, it's really up to the caregiver and the Respite provider to have that agreement. But we find it's mostly helpful. We need to give somebody here the averages. Like, this is what we see. This is what the common rates are, and helping people how do you have that conversation with the respite provider, because that may be a new experience for the caregiver. And then thinking about schedule. Again, I think this is where it's really helpful to have those conversations with the caregiver. So it's not just, here you go, here's your total grant, use it when you want to. It's like, yes, you're using it when they want to, but helping them think about what's the frequency, how long would you want someone to be there? What's the minimum number of hours we can actually get somebody to come into a home? But if you're going to hire somebody for 4 hours a day, and they say, I want to use it maybe 3 times a week, then we can do the math and say, all right, well, this means that you're going to get it for this many weeks. Does 3 days a week make more sense? Does 2 days a week make more sense? Because then you'll have it for this long, and thinking about being able to plan out the use. So really having to work with the caregiver around how the respite is going to be set up. It tends to be more helpful for people who don't feel like I've got to use it all at once, and then I'm left with, the next 10, 11 months of the year because I used it all in 1 month. Or does it make more sense to try and spread it out a little bit? Obviously slightly different if somebody is going to, go out of town. We see people trying to go visit their kids or, go to graduation, that's going to be a different use case. But for people who are saying, I have no help, I just want to have some breaks. All right, let's talk about how to spread it out. What's the minimum number of hours that you feel like you can really get away and do something? 4 hours in the Bay Area traffic can go really quickly. So if they're trying to go do a few things and see people, they actually might want longer. But again, that's that conversation and that really kind of planning with the caregiver. CareNav is our client record system. That is where we track all of our units of service. And that is where we enter our kind of respite grants. It allows us to track kind of the hours that they've used, when they've gotten paid for reimbursement. So again, being able to kind of help keep the caregiver up to date about how many hours they have left. It updates also on their client dashboard, and I have some screenshots of that I'll show you. But with CareNav, it is both our backend client record system, and it is also a caregiver portal where they can log in and see a dashboard. And one of the items that is on their dashboard is information about their service grant. So they can see how many hours they have, how many hours they have used, and what is remaining. So that way they have easy access to that information and not just calling us, which they can also do. CareNav also generates our service authorization form, which is our respite authorization. It is our timesheet. It is how people track the hours they've used and what they send back to us. And then through CareNav, we can also kind of monitor the use. So we can run reports that we do at least once a month that shows, here's everybody who's been authorized. Here's how much people have been used. Because we know caregivers who say, I need respite, I'm interested in respite, not all of them initiate it right away. There's all those different barriers around feeling like it's one more thing to do, having trouble with scheduling, somebody gets hospitalized and something comes up. So we want to be able to kind of track and monitor that use and to be able to follow up and help brainstorm issues or problems with the caregiver as they come up. So having some method to be able to easily look for who's used, who hasn't used, did they use for a couple months and then they stopped and they haven't been, all right, something probably happened, something's going on, and we need to follow up with them. We send that service authorization form to the respite provider, whether it's an agency or a day program, or if they're hiring directly, we will send it to the caregiver to share with them. And then really, again, just being able to follow up with clients on those issues. We have, and I don't know how easy this is going to be to read, but I know Jill has copies of the slides that she will probably share with people. We have an agreement and waiver form when we authorize respite. It covers both through an agency or that vouchered service, as well as the direct hire. We are aware that when people are hiring privately, they may be considered a household employer. And what does that mean in terms of taxes and responsibilities? And, we have been very clear just in terms of our liability and our, responsibilities, what we can and cannot do as a nonprofit, that we do not want to be, hiring or bringing in these providers as contractors and 1099s. So we tell a caregiver, you are hiring them. You may be considered a household employer, depending on how many hours, how much they're paying, all of those tax questions. So we will give them information and guidance on how they find that out. We will let people know, we are not tracking or reporting that information anywhere. We know that people will hire sometimes, again, family members, friends, community members who might be undocumented. And it's like, hey, that's up to you to do. If you have worked it out with them, essentially, we're kind of staying out of that. We want to make sure that you know what your responsibilities are in the legal requirements, but that's really kind of up to you and to what you are comfortable with. And some people will say, I'm not, let's do an agency instead. And again, fine, it's about those options. And as long as caregivers are educated about what the resources are, what the options are, what the pros and cons of them are, then we just want to make sure that we can support them with making the best decision for themselves. So we provide this to caregivers at the initiation of respite, so that they understand those options. And then, it also covers things that are simple as, it's going to say the maximum of your respite grant, and that's the maximum. That's all we can pay for, that it's based on our funding available. So wanting to make sure that people are aware that we will help you track how many hours you have, but that's how many hours you have. And so again, just being very clear in that communication. Our service authorization form is as simple as it can be. Most of the top information we will have filled out, obviously caregiver's name, contact information, care recipient, amount of respite they're receiving, and what that hourly rate is, and who the person who authorized the FCA was. So if it goes to a home care agency, they have all of that. If it goes to the caregiver, obviously they know their own contact information, but then they clearly have what the total authorized amount is and what the rate is. As they use it, they fill it out. So, they use 3 hours on the first, 15 hours on the 6th, or 6 hours on the 15th. They fill that out for those number of hours. And then the person who provided the care signs it, and the caregiver signs it. And that's that documentation that we need under our contracts to be able to show proof of, yes, the care was provided. They are both essentially attesting to those hours were provided. And then we send the check back out to the caregiver to reimburse them. Most grants are used over multiple months. So when they send it back in, for the month of September, we're going to process that. And then we're going to send them a new one for October that then shows how many hours are remaining. So we do that over kind of the months that a caregiver uses it. I think what we've seen in the last few years is sometimes the biggest challenge is the mail, and how long it takes things to get to and from people. That has been a little bit more difficult in recent years. So we have caregivers who will scan it to us and send it in because they want to know for sure that we got it. We have people that will take a picture of their timesheet on their phone and send it into us that way. We've tried to make it as flexible as possible, knowing that there's just sometimes the mail is takes a little longer than it feels like it should, and that can just be a little stress point for people. So we do as much as we can with that, and then some of it we only have so much control over. So some of the challenges that we see, I think the biggest concern people have is that they want to have consistent care that's reliable. They don't want people who are just not going to show up. They want to know that somebody can provide the care that is needed, so that they don't have to feel like I have to be worried, are they going to take care of the person correctly? And so I think that's where the more choice that families have, the more comfortable they're going to feel with it. Is it somebody that I know and I trust? Is it an agency that I can feel is trustworthy and that I can say kind of yay or nay to, and be like, that one didn't really feel right to me. Can we go with somebody else? So wanting to make sure that we have some options to kind of work with people. And of course, that can be more time consuming, but it helps people feel more comfortable and more likely to actually use the respite when it's available. There are always concerns that come up around immigration and documentation status. We do not require under either of our contracts that we get, proof of immigration status from any of our clients. We don't require that of the respite provider that they are using. But those are concerns that we do talk with caregivers about, in terms of what information we have to share, what information we need to collect, and what information we don't need to collect. So wanting people to feel as safe as they can with using public services and and public dollars, and yeah, feeling like it's safe to do so, kind of no matter the environment. Again, people wanting to make sure that's linguistically and culturally appropriate care, that they have somebody who can provide services in language. And that's where sometimes the challenge of home care agencies is. You know, we work with a number of them. I think they do their best to have as diverse of a pool of staff as they can. But depending on where they live, you know, if we have a client who speaks Farsi in San Mateo County, we are probably not going to find a home care agency with that on staff. If they're over in Contra Costa or Alameda County, possible, like we can do that. So you know, it's where do we see kind of those larger numbers from a particular community, by language, and that may or may not be where that individual client lives. So you know, that's where then we'll talk about, okay, well, who do you know in your community? Reach out, ask around who has hired somebody, and help people think about that. And then concerns around cost, again, even when it's a grant, you know, they're not paying for it, we are. They still have to think about upfront, do I have to pay? Is that realistic for me? What does that mean in terms of taxes? We get a lot of those questions in that reimbursement model. It's like, oh, is this taxable for me? It's like, no, it's not income for you. It's a reimbursement for you for the person you're hiring. So this is not considered income for you. And so helping people kind of understand that, and also being aware that we are not tax professionals. So we cannot give tax advice for people. So we have to think about kind of our scope of practice, and how do we give people the education they need? How do we connect them to existing resources? And sometimes how do we just talk to them about bringing in in-home care in general? Maybe when the person you're caring for doesn't think they need any help, doesn't think you need a break as a caregiver, because what are you doing? You don't need to take care of me. So having those conversations with families and coaching them and providing education, particularly on dementia, about how you might introduce in-home care. So we have a fact sheet on hiring in-home help, but we also have an article that I know I refer to frequently that's introducing in-home help when your loved one says no. So those are conversations and education that we generally will share with caregivers. Our website, this is kind of where people come in for resources, but then you also see the register button, which takes people to CareNav, which is their caregiver portal. It is HIPAA compliant, that they can sign into, gets them additional resources, kind of tailors our educational content to them, and can be a way that people start receiving services. It might be the intake that they receive and then get follow-up. But they get to their dashboard. And so this is kind of where they would first start. And again, they'll see resources, educational materials, kind of updates. And then that menu bar on the left, you'll see something that says records. And that is where people would see their information about their respite grants. And so these are two kind of test ones that are in there. So if the information looks a little funky, that's kind of why. But you see kind of their total grant for this first one. Rick Lee, who was our kind of fake caregiver in this situation, got a $2,000 grant. They've used some of it, so they have 1,800 remaining. Kind of here's what the rate are, here's what the units are, so that they can kind of see that information. And then if we're going through a home care agency, same thing, we're tracking that in it. So this is something that the caregiver can view and see. They can also request another copy of their timesheet when it didn't come in the mail, or they lost it, or they can't find it. That we see come up frequently, where we have to resupply that. And so some people are still going to reach out to us, ask us to resend it, but it's just one more way that people can also get to that timesheet when they're delivering their respite. And I think that's kind of the overview that we wanted to provide of our model. But, you know, as Kathy said, we really wanted this to also be a conversation of what questions you have, what are kind of our experiences around utilizing and processing respite. You know, we personally in the last year, kind of our total grants, we're probably close to $400,000-$500,000 because of some of that additional money. We had pretty significant respite funding last year. It might be more than that. Can't do that math that quickly in my head. But we have a lot of respite that we're processing and tracking in the year. So I'm going to stop share, and yeah, I think we'd love to see if there's questions or comments or other information that people were looking for that that we didn't get to. I don't know, Kathy, if there's anything you wanted to add from what I went over as well.
Thank you both.
Very
That was really incredible presentation. Does anyone have any questions? Please feel free to come off mute or put your question in the chat if you're more comfortable doing that. Any questions?
I see one, is there any new training for respite care managers? So do you mean like our family consultants, those who are processing and authorizing the respite?
I would go with that because,
Okay.
I mean, the structure is that you might want to talk about the structure of the staffing.
Yeah. So yeah, our family consultants, there's quite a bit of training when people come on. Most of the time our family consultants are master's level. Social work, MFT, gerontologist. So they, depending on what experience they come in with, you know, we have pretty significant training around dementia, around caregiving needs, around community care options. What does respite look like? We, you know, have everyone shadow existing staff so that they can see the full assessment process. And we do have, you know, training around kind of doing the assessment itself. So looking at what are those standardized measures, what are the issues that we're looking for when we're asking questions, and kind of what are those needs. But I will say, even with that, sometimes having people come in who have been working in the field for years or are brand new to it, the idea of authorizing respite can be a little overwhelming sometimes for people. Like, you mean I just decide based on my conversation with the caregiver how much they should get? So it's usually at the beginning, and there's quite a bit of individual and group consultation when we're talking about kind of respite and delivery of it. And what are the needs? What are the things to ask caregivers? You know, here's how much we have in a particular county or under a funding source. So, you know, here's maybe the range of respite that we might think about. But then it's also based on how much help does this caregiver have? What is the complexity of care? What are we seeing in terms of, you know, we do the Zarit burden scale, we do the PHQ-9 depression screening, loneliness scale. So we're looking at kind of what we hear from the caregiver in those measures in terms of where there is a highest need. And so how do we then decide what is the appropriate respite amount? And then in terms of the use, a lot of that is, helping staff to understand what are the questions to ask the caregiver, what's the information they need to be provided to understand their options, and how do you work with them around that. So some of that is training materials that we have. A lot of that is in shadowing and in supervision and in consultation, because it's really having to look at those individual situations and how do you kind of assess and use your judgment based on what is available in terms of respite options and what we have. Amy?
So there's a
Kathy,
question. Amy, you want to
okay.
go?
Yep. Hey, thank you for the presentation. And I'm just trying to figure out, and I saw that Celeste is on from Illinois Respite Coalition, and Jill might be able to help too. I'm just trying to figure out, like, try to compare apples to apples. You know, the way that Illinois is structured and California. I just want to make sure that I'm understanding your structure correctly. So do you have you know, Kathleen had mentioned, like, back in the 80s, you kind of, so am I understanding that you kind of put all the respite under one umbrella? So it's like the Older Americans Act funding that the AAAs have, but then also, and then this is where Jill and Celeste, I might need your help. So if you were to compare, like, the way that Illinois does it, like, then you have, in Illinois, we have the Illinois Respite Coalition for the emergency respite. And then we also have Illinois Department of Human Services that has, like, respite for developmentally disabled, and, you know, our rehab services. So I'm just trying to understand if it's like, if it's, you or maybe you can help, like, with the older Americans. So you take care of the Older Americans Act respite as well?
So let me start out at sort of an omission in the beginning. Our population that we serve is those that have adult onset cognitive impairments occurring after the age of 18. We do not serve the behavioral health population nor the DD population.
Okay.
We also have expanded that for chronic care conditions under the Older Americans Act, because the presence of cognitive impairment is not the criteria for Older Americans Act access for the Title III program. We blend a variety of funding on the back end, but the staff, I think, need to keep cognizant of, what funding sources are there. So in other words, everything on the back end admin side of CareNav is Title III respite. Some respite is provided by counties. A couple, there have been some counties that have provided respite. Other kinds of programs for respite, Christina can name them all. But so there's different sources of funding that's coming in. We blend the funding and the back end according to the eligibility criteria for each and the population that we serve. So the family member has no idea who's paying for respite. They just know they're getting respite, and that's the way it should be. They don't need to worry about that stuff. And so we do blend it on the back end, but it does take understanding if there's any differing criteria of eligibility. Takes understanding by the family consultant of what those conditions might be. Did I explain it correctly, Christina?
You did, yeah.
Enough?
So we do have this, so we put it all into CareNav. It spits out reports that lets us track it. And we keep that then on a spreadsheet that we then update. We rerun the report at least monthly. As it gets closer to the end of the fiscal year, we tend to run it more frequently because we just need to really kind of stay more current on what people have used. But it lists, it's also the spreadsheet then that our staff look at. And I will pull it up and I can show it really quickly if it doesn't totally overwhelm people. But it shows all of our different funding types. So if we look at, say, Alameda County, where we have Title III money, and here's how much we're getting in respite from Alameda County. But our money that comes from the state under the Caregiver Resource Center, that can be used across the counties. Now, there is, again, some differing eligibility, but there are many clients who would be eligible under either. So then we're making that decision, which pool of money are we pulling from based on what clients we're seeing, how many clients are we seeing under one funding source or another, how much have we spent out. If it's counties that we don't have the Title III contract and we only have the state money to use, we need to make sure that we then always keep in mind that we need enough for those clients, separate from people who may be eligible for another funding source. So it is, again, especially when staff start, it is something that anytime we are authorizing respite, this is a conversation for quite a while as we talk about how do you determine amount, how do you pick kind of which funding source you're using, making sure that you're keeping in mind of eligibility. And year to year, it varies. Respite amounts that are available will differ. If there's special funding that has come in, they have different timelines sometimes, so it is a lot to track. And we don't want the client to kind of see or have to deal with that. So we are trying to kind of track and manage that on our end.
And Christina, did you say, or you and Kathleen say that you served like last year 1,200 to 1,500 families, and then how much is it? Was it again the dollar amount for the last year, kind of ballpark?
There's actually I'm in error there. Those are state. Well, actually, it's a little bit more statewide in respite. I'll look it up real quickly. But I'm using, I'm flipping back and forth between state data and FCA data. So you might want to talk about FCA in terms of how many clients that we have, since you have that off the top of your head.
Yeah, in the last fiscal year, unduplicated clients that received more of these individual intensive services, not they participated in a broad community education program, but they received assessment, counseling, case management, support group, all of that, was I think close to 1,400 clients that we served. Not every single one of them received respite. Not everyone needs it. Not everyone's eligible for it. Not always appropriate, but that's the number of clients that we served. And so respite is kind of always one of those pieces that we're thinking about and talking about as a part of that. So I actually was looking at our budget this year, and I was off. The amount that we have this year in respite is almost $900,000 in respite that we are processing this year. So it's a lot, but it is coming from multiple different funding sources. And I did see that there was a question in chat about, is there a cap for respite per recipient? That is one of the hardest things, because again, the funding varies, what someone's eligible for varies. So I will just give an example in one of our counties. We have in Alameda County this year about $183,000 allocated for respite. So it's a fairly high amount. You know, we generally have a sense of how many caregivers per county that we serve in a year. So it gives us an estimate. If every one of those were to get respite, here's what that would look like. But we also want to make sure the respite is really, again, very person-centered in delivery. And it's not just everyone gets the same amount, but it's what's the need. So we tend to look at it in terms of a range. And in years where we have more respite funding, and I'm not as worried about it running out super early, you know, we might be able to say our grants could be an average anywhere between $1,500 to like $3,600 in the year, because we might pull from different funding sources. Within that, you know, we're looking at, okay, what is the actual need for this client? And there's not some super prescriptive formula. This is really kind of based on that clinical judgment about what we're hearing from the caregiver about what their needs are, how they're going to use respite. You know, if they need it to use through a home care agency, dollar amount, we might go up a little bit because it means the hours that they're going to receive is going to be similar if they were hiring privately. If the caregiver needs to have a surgery and we're looking at their recovery, we're probably going to go on a higher amount for that than somebody who maybe has some supports from other family or friends, still needs more, but has some support. So it's a question we get a lot from like other providers when we're doing in-services. And they're like, well, how much is the respite? And I'm sure we frustrate them because we will not give amounts, because it depends on the year, it depends on the county, and it depends on the caregiving situation. So it's part of our regular conversation in our staff meetings to be like, okay, where are we at? What does this probably look like given our average numbers that we're serving in terms of what is kind of the maximum that we can do for respite? And we may also have times that we give a client a respite grant at the beginning of the year, and we give based on the amount that we think is going to make sense given our budget and their need. We may hit a point later in the year where we realize we still have money and we know they could use and benefit from more. We may be able to do second grants for people, again, kind of within what is our reasonable level of funding that we have. So I know that wasn't like a super straightforward answer, but it's kind of our internal process of what we go through and trying to make this work given all the variables. Jill?
Yeah, I just wanted to, I'm not sure if Amy was asking her question in the context of what a lifespan respite grantee may do or is required to do. And I just want to clarify so that you know, FCA is not a lifespan respite grantee, and California does not have a lifespan respite grant. So I don't know if that's what you might have been alluding to. And we do have a handful of lifespan respite grantees who run lifespan respite self-directed voucher programs who operate very similarly. They may have multiple funding sources. Some of the money's coming from lifespan, some is coming from other state agencies, and it's all blended on the back end, and they award the funding based on the eligibility criteria for those particular funding streams. And that really was the dream of lifespan respite. That's what it was supposed to be. A way to work across agencies, across disabilities and age categories, and have a seamless funding stream for family caregivers, regardless of what eligibility criteria they met. But given that the lifespan program has never been fully appropriated, there really are only a handful of states that are able to function that way. I just wanted to clarify that. I think
And-
Megan had a question too from Colorado. Did you, Megan? You had your hand up for a minute. Oh, you're
No,
muted.
I just wanted to, I just want to say thank you for the CareNav information. I didn't know if it was a program of Family Care Alliance or if it was available to other people. And I looked it up and it looks like I could probably access it myself. I'm sure it's very expensive, but
So
just,
CareNav was actually developed out of FCA. We have a tech
Okay.
partner, and which is why it works the way it works, like
sure.
less hassle on the caregiver. People can actually start their the process of
Mhm.
getting services by filling out an intake. We have about 40% who do before they come in, but on the statewide basis, about 20% of folks start their CareNav usage that way.
Okay.
So we're looking at that. We've been asked that question. I don't really have an answer for you.
Sure.
And it is actually, it's a very time-consuming process. When we went through we got an augmentation in 2019 to essentially provide more digital delivery of services so we could scale
Okay.
faster. And CareNav was part of that process of doing that. But just suffice to say, in fiscal year 20, we have a July 1st to June 30th fiscal year. We were in the middle of installing CareNav across all of the rest of the centers and training staff on digital service delivery and how to use CareNav, how to, really kind of turning around. And then we all shut down for the pandemic. So we continued that process. We did get everybody up and running for, about, I would say it's about a 14-month process to train everybody. And which was pretty remarkable in and of itself to get everyone up and running. And then we absorbed an augmentation that brought us back up to pretty much our original appropriation before the recession. And so it's not just using the platform, it's actually understanding if you're going to be doing service delivery. If you're using it as an admin, that's one thing. If you're using it as a portal for families, and then including increased digital service delivery, it's really quite another.
Okay.
About half of the CRCs were not HIPAA compliant, for example, and we had to also and build out the infrastructure, the technology infrastructure for the CRCs to be able to do all of the different components of it. So we haven't really looked to clone that anywhere, but it is a pretty involved process. And we are, going across a like-minded system. So if you had organizations at different capacity levels, it would pose some different kinds of challenges. So if you ever want to talk to me about it, I'd be happy to tell more. But in the interest of time, I'll just say that it is a complicated
you.
process. It's ultimately the only way that we have any data, though.
Right. And that's kind of what I'm like. Sometimes right now I'm a one-woman show. Sometimes I have help. So it would be nice to have something like that. So just a lot easier to run reports and stuff. So anyway, okay. Well, thank you. I appreciate that.
Yeah.
Kate?
There was a question on the cap, Christina, for respite. I just didn't really
I
talk
kind
about
of answered that in a very fuzzy, probably maybe slightly unhelpful way, and that there is and there isn't. We have kind of a range for a cap. So it's not a hard and fast rule. I think we tend to stick with like the 3,600-ish as our very upper cap, but really it's based on funding, based on need. So I think internally we look at it as a range. All right, and Kate, and then responding to that in the chat.
Kate has a question from Delaware. Kate, do you want to ask your question? I see you put it in the chat as well. Is that the same
Oh.
question you wanted to ask?
No, I do have another question. I have multiple questions, but
Yes.
let's go with the one that I have in the chart.
Okay. Let's see what flexibility is allowed and how caregivers use respite vouchers. It's completely up to the caregiver. You know, which method they use is really up to them. All of those are available, you know, within kind of our funding being available. So that's that conversation that we have with the caregiver about, here's the option. Let's talk about, you know, based on your situation, kind of pros and cons, what feels like the most helpful, what feels like the fit. But they all are an option for each client. And we just want to make sure that it meets their needs as best as we can. And did
There's
you have
another question. Oh, I'm sorry,
Yeah.
Christina. There's another question in the chat that was one that I wanted a response to as well. I think she's
Yeah.
asking this, and you may have touched on it, but
Yeah.
and a lot of our grantees are starting to ask this question. When you use the reimbursement method to family caregivers to
Mhm.
pay after the fact, what happens when the family caregiver doesn't have the resources to pay upfront? This is an increasingly big issue
Yeah.
for a lot of our programs.
So sometimes, and we will talk with them about, you know, is the person that you're hiring, are they willing to wait? Here's what the time frame is for reimbursement when you send it in, our process speed and getting it back. So we will talk with them about, you know, that, have that conversation, see if that's a possibility. Is that realistic for the person that you're hiring to do? Here's the time frame of us returning, of us being able to process the respite when we receive the timesheet back and get checks out to people. Obviously, some of that relies on the mail, and that becomes an issue that we can't fully control. And so we know that that sometimes is a problem, and we can be as quick as we can, but we can't control then the next step to it. If that really does not seem like a possibility, and they are very worried the person they're hiring is not able to wait to receive payment, the caregiver cannot kind of pay up front for the cost, then that's where we will talk about, let's use, you know, an alternate is to use a home care agency. You know, again, there's pros and cons. It's like they may say, well, I'm more comfortable with this person, I prefer to use this person. Okay, but if financially that's not going to work, is this an option? Is it something that you're wanting to try? So we would try and talk with them about what's the feasibility and the ways that they're able to use it. You know, it may not always be the perfect solution, but that's why we want to have options available and different methods for someone to go about using respite care, so that we can, as best as we can, adjust to what their needs are and what their options are.
I wish our folks from Oklahoma were on, because they're one of the few states that they still require timesheets and all of the paperwork, but they pay the family member or the neighbor or whoever is paying the respite care directly, rather than paying the respite care. But then you run the risk of becoming the employer.
Yeah, and I mean, I have to say, I actually know, and I don't know their internal process, so I'll be careful about how much I say, but the Alzheimer's Association has respite grants, and they do it that way, where they actually then do a 1099 on that respite provider, and they pay them directly. But that's a lot more administrative work on the other end. It does get into those questions around, you know,
Who's the employer?
documentation status and immigration, and even for somebody who is documented and able to work in the country. You know, there's been some years that people are worried about what information they're providing to organizations, and whether that's comfortable or feels safe to do so. So, and then just, the organizational liability of this is now a contractor that you are hiring, and what are the implications and tax responsibilities of that. So it does maybe address that reimbursement issue, but it potentially creates a number of other issues. So it's one that we have not wanted to absorb and take on.
I understand that.
Yeah. And then I see a question about double dipping around accessing multiple respite services. You know, I mean, we ask questions about what sources of help people have. Are they getting access to other paid or unpaid services or supports? You know, we can't like 100% guarantee that somebody is not using other services. And frankly, sometimes it's very appropriate. You know, we will talk about our respite grant, and then, you know, knowing that a lot of people actually need ongoing in-home care, and they cannot afford it, and they do not qualify for Medicaid. And so respite is the only way they're going to get a break. So we may talk about, here's how our respite grant can work. Are you also eligible for the Alzheimer's Association through the Frontal Temporal Association? Like, okay, here's then maybe how you kind of plan for using what services and resources do exist, not all at once, but over time. And so helping people explore all the options available to them. So, we keep that in mind in terms of amount we're authorizing. What are the people who have no other sources of help versus those who might be able to tap into other options? But often people need way more care than any one respite grant is going to do. So, it's just part of that assessment and planning process.
There's a question about hospice services and authorizing respite care. Yeah, this is
We get
interesting one.
referrals from hospice, and I will say we've tried to have those conversations with individual hospice agencies, especially when we get referrals, like when it's very close to death. And it's like, we are not a crisis agency. We will try and respond as quickly as we can, but thinking about what are other options and how much is the hospice provider doing. One of our local hospice providers actually can provide pretty significant respite funding for people. And so we've had that very frank conversation with them about, when is it appropriate to use ours versus theirs? And, especially at what stage of, within hospice somebody is at. Other hospices aren't really providing a whole lot of help beyond like the bare requirements that they have to. So respite is then often totally appropriate. But again, when those requests come in, when it's like, oh, we think this person may have a few days left to live, maybe a week at most, like we may not be able to get everything going, do our assessment, provide the respite, get it started within that time frame. So we really kind of try and encourage when we're doing in-services and education to community providers to say, make those referrals early. We want it to be helpful, not we're trying to cram in care because they need more care than can actually be delivered. And to the question about how quickly, it depends somewhat on how responsive the caregiver is. If somebody calls in today and they do their intake today, we get certain periods of the year where every family consultant is kind of scheduling out several weeks because we just have so many requests coming in at once. Other times we're able to do it within a couple weeks, and respite can start then often within a day or two after the assessment, because they either have somebody or we have, several home care agencies that we can tap into and they can staff. So it just depends on what our volume looks like at any one time. And that just, goes up and down during the year.
The other thing to keep in mind in this is that respite is one of a variety of services that families need. And so it is a discrete service to be sure, but it's typically not the only service that gets used. When we look at what service utilization of our families, it's usually definitely consultation and working with the staff to put together a care plan and talk over all of the different issues that are facing families. That's the most often used. Everyone eventually wants to talk to somebody who knows more than they do about a particular specialty need. And so families use this. But we don't market ourselves purely as a respite program. We market ourselves as a caregiver support program. And so it's just one of many things that families need. And sometimes people come in and respite is not necessarily their immediate need, but counseling may be, for example. So we try to look at the whole picture. And so we don't design it just around one discrete service.
Yeah. And so the other questions in chat, I mean, the challenge is like we've tried to mitigate those as much as we can with having that flexibility of delivery, of hiring privately, having multiple agencies, having multiple options for caregivers so that we can try and reduce some of those barriers. Doesn't mean that it's always going to be perfect with every client, but just some more flexibility and options that we have available, then the easier it is to reduce some of those challenges and barriers that caregivers might face. That discussion of respite and availability, if a caregiver calls us and specifically on intake says they're interested in respite, we'll let them know we need to do the assessment to talk about it, but they are able to kind of do an initial screening based on our requirements that they're probably going to qualify, or, oh God, that might be iffy. And so, we'll try and kind of be upfront with people and clear about setting expectations at the beginning, so that they're not, looking for something that is not going to be doable within what we can provide. But definitely when we do the assessment, that's part of that conversation, is to say, this is what respite can look like and what's available. There's no application that people have to fill out. Some people may self-administer part of the assessment. We may fully do it with them, but there's no like separate application for respite. It is like, does this make sense? Is it available? Does it fit within what your need is? Okay, then we're going to make that available to you. But then also, because we are doing an assessment, we're able to then identify other options. Could they be Medicaid eligible? And so we might do respite, but we're also going to talk about Medicaid planning. Are they a veteran? And there actually might be programs to the VA they can't. We want to try and connect people to any of those other options that might be available for them beyond just our respite grant and our services.
Well, we are at our time, so I want to be respectful of that and thank our presenters so much for an invaluable presentation. And I know that there are still unanswered questions in the chat, and I'm wondering if we might send them to you, Christina, or would that be too much of a burden?
No, feel free to send them. I was trying to catch them, and some of them I may have responded to, but yeah, feel free to send them, and I can send something back to you with them. Because
And I also have a bunch of questions.
Okay, yeah. I wasn't
We didn't
sure
even
how
get to the
quickly
tax issues, which opens up a whole can of worms for our network, but I really would love to pick your brain around those issues as well.
Okay.
But
Is there an
thank you.
email? Is there an email so I could forward my questions to? Did I miss that?
It might have been on one of the slides, but I'll stick it in chat.
Thank you so much. It's like my mind is blown because I just didn't realize like just all these conversations around different ways of respite and different communities being served. I wasn't even thinking of a lot of them. I work for Riverside Community Care, and I work for the Caregiver Resource program as a family partner, and I'm just shocked that just the plethora of knowledge and just the diversity of the people and the scope of people you help. So it's amazing. My mind's blown, and so I have to process. So
If you're not familiar with Arch resources too, please feel free to
Yes.
visit archrespite.org. You might get a lot of your questions answered there as well.
And we'll send some key links to you, Jill, because we just released a training on improving practice and working with diverse caregivers, for example. That is really stories that are told by our caregivers and responses to that. And some other things that I think might be particularly of interest to your group.
Thank you again so much for your time and
You're most
for
welcome.
all this great information. And thank you to all our grantees and partners and Arch members for joining us today. And we will forward all this great information to you.
Okay.
And thank you for being with us all. Take care. We'll
Thank
talk with you
you.
all soon.
Thanks.
Thank you, Christina and Kathy. Thank you.
Bye.
Bye.